I think, and you're looking for biomarkers, I think probably the best biomarker you will have is elastography of the liver. So you can do elastography by MR or ultrasound. And I think the growing opinion is that elastography of liver stiffness will be your best biomarker for the status of the liver. That's being shown over and over again in almost every kind of liver damage. This is for Dr. Bridgewater. So I was a little surprised by the small number of perihilar cholangiocarcinomas in your study. And I didn't know whether there was a selection bias somehow in terms of the total number of patients screened and then entered into the study. That was always been a bit confusing to me.
So, thank you. I don't know. I can't tell you how many perihilar tumors were screened and then didn't get randomized. That's almost up to him, really. That's almost how many perihilar tumors get to surgery in the first place.
So, Ben Stanger, University of Pennsylvania. So given that recurrence after surgery is such a big problem, I'm wondering if we can get any sense from the surgical experience of the mechanisms of spread. In other words, I assume after an R1 resection, we can presume that recurrence is from tumor left in at the resection site. But I wonder if there are any clues from the patterns of recurrence, where they occur, either in the liver or elsewhere in the body, what the biology is. Is it hematogenous? Is it a field effect?
Yeah, I mean, that's a challenging question. If you look at each of the different sites, the distal cholangios will behave very much like pancreas cancer. I think overall the answer is, if excluding the perihilars for a second, the idea is probably micrometastatic disease that we can't visualize at the time and hematogenous spread that we just don't know. Hence the approach of kind of a test of time with different therapies prior to undergoing resection. But if you look at, based on site, distal cholangios are going to most likely occur in the liver, again, hematogenously. Intrahepatic cholangio, most often in the liver or peritoneal. And perihilars are the ones that have a pretty good risk of local recurrence, and you'll see the R1 rates are a lot higher there, as Dr. Bridgewater showed. And that could be much more, but when they recur distantly as well, it's most likely liver metastases. So if we can find, as Ted was saying, in terms of biomarkers, circulating DNA, all of these things that we're working towards to really help better select patients for resection, I think that's what we're heading toward, but we're just not quite there.
So just to fill in on that, I mean, there are several bits to that question, obviously, but where do they recur? Well, it's a mixture. And consequently, is it the biology or simply the fact that it's a locally advanced tumor? Again, I think it's going to be, the answer is it's going to be a mixture of those two factors. And any study has got to stratify that very carefully.
Dr. Knox.
Hi, Jennifer Knox from Toronto. A question for Dr. Arain. You mentioned about using larger core needles for tissue acquisition during endoscopic. I guess what I want to comment is how disseminated is that approach now? Are your colleagues more comfortable with it? And what about the situation where you're pretty sure it's cancer? And as you know, we need tissue for genomic analysis and everything. And timeliness is important in sending patients back for other procedures. If you could comment on how well that's being taken up by colleagues.
Yeah, I think in terms of the gastroenterology circles, it's been accepted quite widely because it also reduces the number of passes needed to make a diagnosis, as well as the number of procedures. Our false positive rate, our inability to make a diagnosis on the first EUS has dropped significantly with these better needles. Surprisingly, some of the pushback that's come to us has been from our pathology colleagues who feel that making a smear of the tissue on the spot can be very difficult because it's too thick. But generally speaking, I would say that it's being widely accepted. Most bigger institutions have switched over to these. In terms of getting a second getting the patient back in for another biopsy, it really boils down to how busy the schedules are, but we always try to get them in as soon as possible.
I'm going to do the microphone in the back, and then we'll...
Thank you very much to the panel. We really appreciate all of the comments and the information provided. I had a question for Dr. Bridgewater and for Dr. Arain as well. Dr. Bridgewater, I was wondering if there was any medical reason why the results of the BILCAP study, even though the patients were all resection patients, whether or not the results are applicable to patients in the post-transplant setting, given the similarities in the treatment. If I know that the study excluded people with prior radiation and chemo, and that is part of the protocol for orthotopic liver transplantation, but I'm wondering if that is a medical reason why the evidence on the effectiveness of capecitabine and reducing recurrence in the resection setting would be suggestive of the same data for orthotopic liver transplant patients. And then for Dr. Arain, I really enjoyed the slide on the difficulty of getting an ERCP for Roux-en-Y patients, and it's my experience that the length of the scope is also limiting in terms of the size of the stent that can be placed to 7 French, and so the difficulty of getting the scope to a Roux-en-Y patient means that you're often bilaterally stenting, putting in multiple stents, or you're just limited in terms of the size of the stent. And I was wondering whether or not the advancements that you're seeing in the size of the needles for biopsies, you're also seeing some development in terms of the size of the stents that can be delivered and pushed to patients with Roux-en-Y.
So yes, thank you for that. So we didn't include transplant patients. Remember, we started 13 years ago, and maybe we should have done. But the question is more. The question really is: are transplant patients the same as this lot? And that actually is a biological question, really. We should be able to answer that once we get all the biology out of the BILCAP study, which we will. We have 447 resection samples, and we should get some information out of those.
Can I just add one comment? Dr. Gore just stepped out, but keep in mind the preoperative therapy that transplant patients receive for perihilar cholangiocarcinoma is quite extensive, often 6 months, 9 months, 12 months of chemotherapy while they're waiting in intense radiation therapy, and then a liver transplant. So oftentimes once they're done, putting them on adjuvant chemotherapy is just not feasible from a performance status, and at that point they've had so much therapy, they just need to recover and live life.
With respect to the stents, I think the limiting factor for us is the length of the root limb. If we can get up there with a shorter scope, which has a wider working channel, which is the size of the channel that allows the size of the stent to be determined, then we can use up to 10 French stents. If we do have to use our standard enteroscope, then you're right, the limit is 7 French, but we can certainly do multiple stents. It just takes some time and commitment, but it certainly can be and it has been achieved.
So I think we'll take 3 more questions, so the people at the microscope and then our microphones, and then the panel I'm sure will be happy to discuss with you during the break. So Dr. Valley.
Juan Valley, University of Manchester, UK. Question for Dr. Maithel. You talked about assessing patients for resectability and the concept of borderline resectability. This is largely based on anatomy. What are your thoughts about the role of a functional assessment of the liver and how that changes in patients who may have underlying, say, cirrhosis, or even patients who have undergone preoperative chemotherapy?
Yeah, no, definitely. That probably is a little bit more seen and used outside the United States and also in the HCC population. We talked about a little bit yesterday, there is a little bit of overlap between the HCC and intrahepatic cholangio in terms of the risk factors for development of that. But most often, especially with biliary obstruction, once the stents are put in, the liver function is relatively good. In the U.S., we use a little bit more of a thumb approach, and we use the usual numbers of the child score, MELD score, things like that. The functional tests, like the ICG 15 clearance and all that, those are predominantly used in Europe and Asia, and it hasn't really been much of a problem. We usually go based on a quantity of liver and volumetrics.
Go here, and then we'll go to the combined question.
David Bakes, University of Nottingham. John, the subgroup analysis indicated that the patients with differentiated tumours respond much better than the patients with, poorly differentiated respond much better than those with well differentiated. And given the resection margin is also an indicator, does that mean that if you've got poorly differentiated tumor and a well-resected margin, being on CAPE is fantastic. And if you have well differentiated and a poorly identified margin, it's not going to help.
So, two comments. Thank you, Dave. Two comments about that. Firstly, none of those. If you looked at the forest plots, the error bars were all over the place. So you can't say. I mean, the impression is there. You can't say a lot of that definitely, and certainly the statisticians would wince if you began to say that. And the second thing actually is a very similar point to what I made earlier about this actually potentially being a mix between the physicality of the thing, where the cancer is, the inevitability of the close margins for the hilar resections, and the actual biology of the tumor. We should be able to give you a slightly better answer once we have the biology, but I suspect it'll be one of these Venn diagrams where part of the effect is the biology, part of the effect is the physicality, and you've got to live with both.
Final collaborative question at the back.
Hi, thank you for that. So I have a question about the SBRT or proton therapy generally. I'm wondering if it's still, I guess, a usable therapy if there's been vascular invasion or any kind of metastasis, like local metastasis in general.
So I think that that's a bit of a moving target in regards to the metastatic question. Let me come back to that in a second, though. But certainly for vascular invasion, there's actually a large amount of experience in hepatocellular carcinoma and increasingly in cholangiocarcinoma in using high-dose radiotherapy, be it with protons or SBRT. And it's really quite safe, and in fact, it's an attractive modality in that situation. We use it in some of our more complicated vascular invasive cases where there can be tumor tracking through the hepatic vein up into the heart, and we're able to even safely treat those situations. In regards to metastatic, it depends on two different things. One is whether or not it's the right thing to do. So when we have spots sort of far away from each other in the liver, it becomes an issue of will someone benefit from going through the radiation. Now, having said that, there's a situation that I have right now with Andrew Zhu where a patient has a very large tumor in the left and a small tumor at literally the exact opposite end of the liver on the right. But that patient's gone through several months of chemotherapy with no progression, and we're going to do the radiation now to see if we can at least provide a durable chemotherapy holiday. So I think that it's very situationally driven in regards to that specific scenario, the use of high-dose radiotherapy for metastatic disease.
Thank you.
And we combined ours not only to show the power of the green people, but also because mine is just a suggestion to end on. And it's not just for the panel, but maybe for all of the researchers and scientists and maybe even the foundation. So I'm Mike, and my wife was diagnosed 3 months ago. And one of the things that strikes me is what's the magic of this conference, as Stacy often says, is the interdisciplinarity, but also with patients. I think it would be a great idea to have on a website, and maybe it exists, or poster presentation for a postdoc to list all of the therapies. You know, you've got your chemos, your targeted drugs, your immunotherapies, your radiation, your endoscopic therapies. And because our doctors don't all know all these, you know, you go to a certain place and, you know, they love the Y90. Well, this place loves GemCis. And so for us to be able to have a tool, like almost like a flow chart of like, I've already categorized 24 discrete therapies that would work in this situation, not in that. If there were a chart or something that like we could, you know, have with us, you know, arm ourselves with as we meet with these docs, I think that could be a really helpful deliverable from a conference like this. Thanks.
Let me say one thing. It's a great idea. And really that is our goal. I think you're kind of seeing our vision here. So one thing I would tell you is how important, and I think the doctors in this room would echo this, is how important it is that you go to a place where there is a multidisciplinary team. Because you can't have some of these treatments. There has to be interaction from this whole team. You can You can hear Ted saying he's working with Christina, he's working with Lippy on the, right, it's a team effort. And you're not gonna get that at every center, and we wish you could have that at every center. And that's why you're gonna see us constantly telling you, please get to these centers where you can see these multidisciplinary teams.